In this lecture, we will discuss the meninges with some clinical applications, and then in a part 2, we'll go over cerebral spinal fluid and clinical applications. First, let's just talk about the layers of the meninges. In our brain dissection lab, when we look at the brain here, what we're looking at here is the arachnoid. So we need to sort of peel away the arachnoid to see the pia, which is tightly adherent to every gyrus, okay, and so we have to sort of tease away this arachnoid before we're able to see the peel layer. Now, importantly, blood vessels lie on the pia, and so we'll discuss later on in a lot more detail what can happen when there is an aneurysm that is again lying on the pia. It's an outpouching of the blood vessel wall. And when that ruptures, the blood then is going to go into this space between the pia and the arachnoid. And this space here is called the subarachnoid space. The arachnoid layer, by contrast, we can see it extends over all of the sulci. And then, of course, we have the dura here. Now, the subarachnoid space that we've talked about covers the entire brain and spinal cord. And as we'll say in more detail later, this has a very cushiony, protective effect on the brain and on the spinal cord. There are areas of the subarachnoid space that are focal enlargements. And the two that I want you to know about are the cisterna magna, which I'll show you a picture of in just a little bit. It's kind of posterior to the cerebellum, and the lumbar cistern, which has the most important clinical applications, which is an area of large subarachnoid space below the spinal cord. When you do a lumbar puncture, you're putting a needle in the lumbar cistern to draw out cerebral spinal fluid. So it's just another drawing showing you the three layers here, the pia, the arachnoid, and then the outer dura. So to say a bit more about the subarachnoid space, I mentioned that since blood vessels sit on the pia layer, that if we have a weakened blood vessel and it sort of blows up like a balloon and eventually ruptures, that blood then is going to go into the subarachnoid space. So here we see the aneurysm, okay, and a blow up here. And so that blood goes into the subarachnoid space. Why is that important to know? Well, one of the ways we can diagnose a subarachnoid hemorrhage is by doing a lumbar puncture, because you remember you're drawing fluid out of the subarachnoid space. Okay, another application is if we have an infection of the meninges, and that's known as a meningitis. Okay, and so again, we're going to see a lot of inflammatory cells then in the subarachnoid space if we were to do a lumbar puncture in that patient. Now, in both of these conditions, subarachnoid hemorrhage and meningitis, the meninges are intensely irritated. And so doing anything that causes stretching of the meninges will be painful. So one thing we can do here is we can flex the patient's chin forward, and that stretches the meninges. It's very painful. So patients will have involuntary hip flexion. The other exam finding we can do is to flex here at the hip and the knee. Okay, and then when we try to straighten the leg out here, knee extension, again, we're now doing a lot more stretching of the meninges. That's going to be very painful for the patient. And so these two tests, the Brudzinski and Koenig signs, they're not that sensitive and specific. They can be somewhat helpful if you're thinking you might be dealing with a subarachnoid hemorrhage or meningitis. But neuroimaging, doing a lumbar puncture, these are much more sensitive and specific tests for both of those conditions. So I mentioned the lumbar cistern here, that everything you're looking at here is the lumbar cistern below the spinal cord. And remember, the spinal cord ends at the L1, L2, sometimes even T12 vertebral body level. Okay, so when we do a lumbar puncture, we put the needle in the L4, L5 space between vertebrae. We have the patient curl up like this, which tends to open up that space a little bit so we can get the needle in. And so, if you are able to identify that L4, L5 space, you know you're far below the end of the spinal cord, so you don't need to worry about hitting the spinal cord when you do a lumbar puncture. So normally, the subarachnoid space contains cerebral spinal fluid. Okay, we'll discuss later the composition of that. And so these two things do not belong in the subarachnoid space. Blood, which would indicate an aneurysm that's ruptured, or inflammatory cells, which indicate some sort of infectious process, a meningitis. Here is the the cisterna magna. All right, so this is still subarachnoid space. It's just a focal enlargement. Okay, we can see it's kind of between the medulla and the cerebellum here. Okay, now when I was a neurology resident, there was still a neurologist that would do cisternal taps in the office and would put a needle into the cisterna magna to draw out cerebral spinal fluid. I don't know that anyone is doing that anymore because this is somewhat dangerous. Interestingly, he had a pretty significant tremor, so I remember watching with fear and trepidation as he would do that procedure. Right, so we've talked about the pia layer, the arachnoid, and then we have the dural layer, which is the strongest layer. It has two layers, an outer perosteal and an inner meningeal layer. Importantly, the outer perosteal layer has the blood vessels and nerves. And so, interestingly, the brain itself is not a pain-sensitive structure. If you have someone having brain surgery, for example, you can touch the brain while the patient is awake, and it's not going to hurt. Okay, the dura is very sensitive to pain, all right? And so this is why that subarachnoid hemorrhage meningitis is so painful. And also when we discuss migraine, a very important part of the pathophysiology of migraine is literally inflammation of the dura due to the excessive discharges of nerves here that supply the outer perosteal layer. Okay, so this outer layer is attached to the cranium, and then we have an inner meningeal layer that's attached to the arachnoid. Okay, and we'll see that there are separations between these two layers of the dura that form the venous sinuses. So there are some spaces that are important, either above or under the dura. The space between the outer perosteal layer and the bone is known as the space between the inner meningeal layer and the arachnoid is known as the subdural space, and the space between the outer perosteal layer and the bone is called the epidural space. So let's just start here with the brain. Okay, and so we have the pia attached to the brain, and so this space right here is the subarachnoid space, and so the blue right here is the arachnoid. Okay, so all of this right here is going to be subarachnoid space, right? So again, when you do a lumbar puncture, you're assessing this fluid that intimately covers the brain. Okay, above the arachnoid, we're going to have the subdural space, which is between the arachnoid and the inner meningeal layer. So we can follow the inner meningeal layer here. So here's the subdural space. Okay, so we have an inner meningeal layer and an outer perosteal layer. And notice that between those two layers, you have the venous sinuses. So in this case, we're looking at the superior sagittal sinus. Okay, and then the outer perosteal layer is attached to the skull. And so let me just have you add to this drawing that there is a space here between the outer perosteal layer and the skull that is called the epidural space. Okay, so we have an epidural space here, and we have a subdural space right here. So we can make some important clinical applications here, both that relate to head trauma. So a subdural hematoma usually occurs in elderly individuals, and usually they have fallen and hit their head, and a subdural hematoma is a venous hemorrhage. So we have shearing of these bridging veins that leak venous blood then into the subdural space. Okay, here the blue is the dura, so this is the subdural space. Okay, and this can, as the blood bleeding continues, there's mass effect here on the cerebral hemisphere. All right. In contrast, an epidural hematoma typically occurs in younger individuals, again related to head trauma, car accident, being hit in the head with something. Typically, an epidural hematoma, there's a skull fracture, okay, and the blood vessel that's involved now is an artery. It's the middle meningeal artery. Okay, here is the dura, and so notice the bleeding now is outside the dura. The dura is typically so tightly adherent to the skull. And so in an epidural hematoma, because of that, the blood usually is just able to wedge into a focal area of the brain. And this dura is still able to remain attached to the skull. And this dura still is able to remain attached to the skull. So that wedging appearance into the brain is highly suggestive of an epidural hematoma. The reason we don't see epidural hematomas very often in the elderly is that with age, the dura here in blue gets more and more tightly adherent to the skull. So epidural hematomas more often in younger individuals. And so these are all CT scans of individuals that have had head trauma and an epidural hematoma. Again, notice the wedging into the brain. Okay, look at the mass effect here. You don't even see the ventricles, which are these dark areas here on this side. Wedging into the brain, and here is the skull fracture. Okay, epidural hematomas are certainly life-threatening for several reasons. I mean, you've got this acute arterial pressure into the brain, so the brain can herniate. And also younger individuals don't tend to have much brain atrophy, and so there's nowhere for that pressure to go, and the brain can easily herniate. Okay, here's a subdural hematoma. And notice the different appearance here. Subdural hematoma tends to layer out along the entire surface of the brain. Okay, this is causing some mass effect because notice here's the lateral ventricle on this side, we're not seeing it on this side. Okay, so epidural hematomas just tend to present more acutely, whereas an elderly individual, maybe with Alzheimer's, who hits their head, that venous blood may leak over a long period of time and they may just get confused over several weeks. So it's often a more slow, indolent course. Now, so the dura covers the entire brain and spinal cord. And there are two important infoldings that I want you to know by name of the dura. One that divides the right and left hemisphere, that's called the falx cerebri, and then another called the cerebellar tentorium, which provides an opening for the brainstem, and there's an important clinical application of that, okay, that relates to uncal herniation. So let's say we have a patient here with a subdural hematoma. Okay, so there's pressure on the brain, and here let me just have you label on this diagram that here is a reflection of the dura, and this is called the falx, right here, the cerebellar tentorium. The falx cerebri is right here. So this is the cerebellar tentorium. And we can see that maybe label also this is the temporal lobe that sits right on the cerebellar tentorium. The most medial part of the cerebellar lobe is the uncus. So if you want to just label the uncus right there. Okay, so here we've got a mass effect that's pushing the cerebellum right over the edge of, that's pushing the temporal lobe right over the edge of the cerebellar tentorium. And so the uncus, which is the most medial part we see normally over here, the uncus slips over the edge of the cerebellar tentorium and then has mass effect on the brainstem and, as we'll discuss, frequently on the third cranial nerve. Okay, so I'd encourage you to, in the lab, to spend some time just looking at the dura. Here is the falx right here, and here is the cerebellar tentorium right here. Okay, here's the falx cerebri, cerebellar tentorium, and we can see some arachnoid granulations here, which we'll discuss later. Okay, the falx and the cerebellar tentorium. And just one more picture.